And there's a little bit of overlap with our previous lecture, because obviously things in the chest tend to overlap, but repetition is usually good for remembering stuff. So we'll get started with our first question. So we've got 48% of you have gone with option B, and then roughly 25% have gone with either C or D, and the answer is B. So I find these questions difficult because they're really wordy, but sometimes in anatomy that's unavoidable. But the question is basically asking where is the mediastinum? And the mediastinum is in the midline, and it's everything that's between your left and right pleural sacs. It contains all of your thoracic viscera except your lungs and pleura, which is obviously on your left and right. And it's anatomically divided into superior and inferior, and then your inferior is further divided into anterior, middle, and posterior. So your superior and inferior divisions are entirely imaginary. There's no actual boundary, as there's no physical boundary between your superior and your inferior mediastinum. Instead, the boundary that's been made up is called your transthoracic plane or your thoracic plane, which is basically an imaginary horizontal line which extends from your angle of Louis, which is your manubriosternal joint, and that's the protrusion that you can feel on your own sternum, and it extends directly horizontally backwards from there, and intersects with the inferior end plate of your T4 vertebra. So it's just this imaginary horizontal line, but it's got some uses for surface anatomy, which is why it exists. And this is a diagrammatic representation of that. So your superior mediastinum is everything from your thoracic inlet or outlet, depending on which way you want to describe it, or your superior thoracic inlet, and your transthoracic line here. So there's no anterior or posterior parts of this, it's just considered the superior mediastinum. Then everything inferior to this line is your inferior mediastinum, and then that is split into your anterior, your middle, and your posterior. And we'll talk about that in more detail in a second. So the boundaries of your mediastinal cavity are superiorly your thoracic outlet here, inferiorly your diaphragm, anteriorly is your sternum and your costal cartilages, posteriorly is your vertebral bodies, and then laterally is your mediastinal pleura on your left and your right. Again, just to briefly talk about the diaphragm, so it's a dome-shaped musculotendinous structure, and it separates your thorax from your abdomen, and there are three major openings which we'll discuss later, but they're your caval hiatus, your esophageal hiatus, and your aortic hiatus. Okay, question 2. Okay, so we've got 48% of you have gone with option D, vertebral bodies T1 to T4, and then 33% have gone with C8 to T4. So a little bit of a trick question here. So remember that there is no such thing as a C8 vertebral body. So there's a C8 nerve root, but there's only 7 cervical vertebral bodies. So the answer here is T1 to T4. So just to cover the boundaries of your superior mediastinum. So again, your superior border is your thoracic outlet, and so that communicates with the root of your neck. Anteriorly, it's your manubrium. So remember that your manubriosternal junction or angle of Louis is the junction between your manubrium at the top and your sternum below. So it's your manubrium only is the border of your superior mediastinum. Posteriorly, it's your thoracic vertebral bodies, T1 to T4. And inferiorly, it's your pretend line or thoracic plane. A bit more about this thoracic plane. So it's thought that there are several important important things that happen through this plane. So you've got the bifurcation of your trachea, bifurcation of your pulmonary trunk, and the beginning and termination of your aortic arch. That said, there are other definitions of what defines your aortic arch, so that's not universal. So your superior mediastinum is basically just a conduit for things to pass through, either going to your head and neck or coming back from your head and neck. The main pathologies that you might see in the superior mediastinum are thymomas and lymphomas. So you do have some lymph nodes in your superior mediastinum. Thymus in an adult essentially is non-existent, but you can still get thymomas, and thymomas are more common in older adults than in children. And it also contains various vascular and nervous structures that are passing through. So on that note, this is question 3. So we've got 47% of people have gone with option C, arch of the aorta, and then 25% have gone with superior vena cava, and 14% have gone with esophagus. So the key here is which of these is only in the superior mediastinum, and the answer is arch of the aorta. So if you remember back to a couple of slides ago when I was talking about the boundaries of the superior mediastinum, I said the T4 plane is considered the start and the end of the arch of the aorta. So everything, obviously the arch of the aorta is just part of the thoracic aorta, but all the other bits are considered either the ascending or the descending, and only the arch is in the superior mediastinum. The esophagus is partially in the superior mediastinum, and part of it is in the posterior mediastinum, posterior inferior, I should say, mediastinum. The superior vena cava is a good thought, but part of the superior vena cava is also in the middle inferior mediastinum, which is why that's not correct. The thoracic duct does pass through the superior mediastinum, but it also goes through the posterior inferior bit, and the phrenic nerve also goes into the, I think it's the posterior, but I'll check that later, inferior mediastinum. So The contents of the superior mediastinum are as follows. So you've got the thymus, which is essentially non-existent if you're an adult, part of your trachea, most of your trachea actually, esophagus, arch of the aorta, and then the arch obviously gives off 3 branch vessels, which are your brachiocephalic, which supply your right head and arm, your left common carotid, and your left subclavian. Your superior vena cava, and also the things that make it up, which are your brachiocephalic veins. You've got some nerves, your vagus and your phrenic, thoracic duct, lymph nodes, and then smaller arteries and veins and some muscles. And this is a diagrammatic representation of this. So this is at the level of T1, so it's quite high up in your superior mediastinum, and you have to imagine that you've cut through somebody and then you're looking at them from below. So this is your right side and then this is your left side. So your mediastinum is basically this bit here. So the lungs are not part of your mediastinum, remember that. So you've got your brachiocephalic artery on the right, and then you've got your left common carotid and your left subclavian on the left. Your thymus would sit somewhere around here, but you wouldn't normally see it. And you've got your internal thoracic or internal mammary arteries, which run down the anterior inner part of your chest wall. You've got some muscles that we'll talk about later, sternohyoid and sternothyroid, which are very anterior in the superior mediastinum. You've got your trachea, and directly behind it, you've got your esophagus. And then you've got your phrenic nerve here and your vagus nerve here, and they normally go with your carotids or brachiocephalic in the neck. And then you've got some paraspinal muscles as well, more posteriorly. So briefly talking about your arch of the aorta, as I said, there are 3 branch vessels that come off it. So your brachiocephalic is your first one, and that's a classic. They love to ask you that question in anatomy SBAs. What's the first branch of the arch of the aorta? It's brachiocephalic. And it supplies your right arm and your head, as I said. Then the next branch is your left common carotid, and then your left subclavian. And they're your only branch vessels of the arch. Your superior vena cava is formed of your left brachiocephalic vein and your right brachiocephalic vein. So their confluence marks the start of your superior vena cava. And it descends basically vertically through your superior mediastinum. Once it meets the transthoracic or thoracic plane, it magically then enters the middle mediastinum, although, as I said, there's no actual division there. And once it's in the middle mediastinum, it also pierces through the pericardium. So part of it is pericardial, or within the pericardium, sorry, I should say. And it terminates at your right atrium, and it basically returns all the blood from your head and your arms. Why is this important? So there is a condition called superior vena cava obstruction, which occurs when you get either complete or near complete occlusion of your SVC. Most commonly, this is because you've got something from the outside which is pushing it shut. This can be either a lung cancer or it can be from lymph nodes from something like a lymphoma. And what happens is when you close off your superior vena cava, the blood no longer has an easy way back to the heart. The body tries to compensate, so it opens up a bunch of collateral vessels to try and get blood back to the heart. So what it does is it tries to get the blood from your head and your arms and your upper chest. It tries to get it to your abdomen so it can come back from your inferior vena cava instead. So what you might see clinically is that the patient has got loads of prominent collateral vessels all over their upper chest. And there's also this thing called Pemberton's sign. which is basically where you ask a patient to put their arms up for a minute, and it causes them to get facial swelling and cyanosis and respiratory distress. I've been told, I've never seen it myself, but I've been told that it's quite dangerous to try and do this to a patient because it can cause cardiorespiratory collapse. So it's more of a theoretical sign and not something you should be attempting to elicit on the ward necessarily. Other symptoms that you can get with SVC obstruction include shortness of breath, facial and neck swelling, because if you imagine the blood's not coming back or not getting drained from your face, your head and your neck, then you can get swelling because of that, and you can get cough and dysphagia just because of the swelling. The cough is probably more likely to be related to the cause of the obstruction rather than the obstruction itself. Briefly talking about the vagus nerve, so it's cranial nerve 10. There are two of them, right and left, as with all cranial nerves. The right one runs parallel to the trachea, and it passes behind the SVC and the right main bronchus. The left one runs between your common carotid and your subclavian, and it passes over your arch and descends behind your left main bronchus, but it gives off this left recurrent laryngeal branch. The right one has a recurrent laryngeal branch as well, but it's different because the left one passes under the arch of the aorta and then goes back up towards the larynx. And it is important in controlling your vocal cords. And the clinical relevance of this is that if you get a palsy of your left vocal cord, you need to think about something that's either invading or compressing your left recurrent laryngeal nerve. So you have to think, could there be something in the chest around the aortic arch that is causing this rather than just up in the neck? If you're considering a cancer that's causing a laryngeal nerve palsy on the left, you also have to image the chest to look for that. The phrenic nerve, which we briefly spoke about during the lung talk, as I said, it's made up of nerve roots C3 to 5. They pass in front of the anterior scalene muscles, and they enter the superior mediastinum just lateral to the great vessels, so your arch vessels. They descend anteriorly into the middle mediastinum, and they pass in front of the hilum and also in front of the heart. There are three muscles in the superior mediastinum that we should briefly discuss. There are so many muscles in the neck, and it can be quite daunting. But the good thing is that a lot of them are named kind of logically. So you've got your sternohyoid muscle, and it's named after where it comes from, where it goes to. So it comes from the posterior aspect of your sternum or manubrium, and it goes to your hyoid bone, so sternohyoid. And then you've got your behind it, you've got your sternothyroid, which goes from the same parts, posterior aspect of your manubrium, and goes to your thyroid cartilage, which is a little bit shorter than your sternohyoid. And then deeper, just in front of your vertebral bodies, you've got your longus coeli, which isn't named logically. And they come from your transverse processes, and they insert into your the anterior arch of your C1. Moving on to question 4. So we've got 64% of you have gone with option D here, thymus, and then a minority have gone with the other options. So the answer here is thymus. So the anterior mediastinum. So in all our lectures, we're going to call it the anterior inferior mediastinum, and the middle inferior and the posterior inferior. It's worth knowing that in clinical medicine, you often cut the inferior. You just call it the anterior mediastinum, the middle mediastinum, or the posterior mediastinum, because it's just commonly understood that you're automatically talking about the inferior part. So just to be aware of that. So the anterior inferior mediastinum, it's bordered by the sternum anteriorly, the diaphragm inferiorly, the pericardium, the anterior margin of the pericardium posteriorly, and then our pretend thoracic plane superiorly. It doesn't actually contain much, so it mainly just contains fat and a few lymph nodes. As a child, the thymus tends to extend into the anterior mediastinum, but you should not ever be able to see thymus in a post-pubertal person within the anterior mediastinum. And if you do, then you should consider whether the thymus is pathological. So is it a thymoma or is it a lymphoma? So remember, the thymus is a lymphoid organ or a lymph organ, so you can get lymphoma within the thymus. Moving on to question 5. We've got quite a spread here. So 33% of you have gone with option D, 21% have gone with option C, 19% with E, 17% for A, and 10% for B. So actually, the answer here is E. So the question is, what's the posterior border of the middle mediastinum? So the posterior border is the pericardium, and we'll go into that in just a second. So we've lost the poll now, but I think a lot of you had put D. Yeah, so a lot of you had put D, and this would be it would be part of the part of the posterior border of the posterior mediastinum, but it would be further down than this. Some of you would put C, which is pleura of the lungs, and that would be the lateral border of any of the mediastinums. So E is the answer here. So just to go through the borders of the middle mediastinum. So your anterior border is the anterior margin of your pericardium. Floor is again the diaphragm. The roof is again the thoracic plane. Your posterior border is the posterior part of your pericardium, and then laterally it's the pleura. So most of your mediastinum is your heart and your pericardial sac, but there are also some additional things in there, which are basically the big vessels that come off your heart, mostly your SVC, pulmonary trunk, and pulmonary artery. And also your tracheal bifurcation is technically within your middle mediastinum, because if you remember, the thoracic or transthoracic plane is considered where the trachea bifurcates. So below that must be within the middle mediastinum. So the origins of your great vessels, so your ascending aorta or aortic root, they give off your right and left coronary arteries within the middle mediastinum, and then it ascends, and as it passes the thoracic plane, it then becomes the arch of the aorta. Your pulmonary trunk, which comes off your right pulmonary, your right ventricle, passes vertically and then bifurcates into left and right pulmonary arteries. And then, if you remember, the superior vena cava comes from your superior mediastinum and then crosses our imaginary line, and then becomes part of the middle mediastinum and also enters your pericardium. So that's basically all we've got to say about the middle mediastinum. So moving on now to question 6, which is about the posterior mediastinum. So we've got 42% of you have gone with option B, and then it's relatively evenly spread between the other options. And the answer here is option B. So the question is, what's the anterior border of the posterior mediastinum? These questions are always really wordy, and they're quite difficult in that the descriptions require so much thinking just to stay concentrated enough to try and understand what they're getting at. You know, like 2 hours into an exam, when you're answering a question like this, it's so easy to get it wrong. But this is why we produce these kind of questions for you. So hopefully you get used to the way in which things are worded like this. But yes, the answer is posterior margin of the pericardium. So the posterior inferior mediastinum is, unsurprisingly, the posterior bit. So the anterior border is the posterior border of the pericardium, as we said. The floor is again the diaphragm. The roof is again the thoracic plane. And then the posterior border is the vertebral bodies, so T5 to T12. Next question. So we've got 40% of you have said D, kidneys, and then a smattering have said the other options, and the answer is D. So the key is which is not a branch of the thoracic aorta, and the answer is kidneys, because the renal arteries come off the abdominal aorta, not the thoracic aorta. whereas all the other vessels, all the other structures, sorry, are supplied by the thoracic aorta. So the descending thoracic aorta is a continuation of the arch. As I said before, one definition is that it begins at the T4 level and it goes through the posterior mediastinum until it reaches the T12 level, at which point it passes through your aortic hiatus and becomes the abdominal aorta. However, there is another definition of where the thoracic aorta starts, which is basically that the descending thoracic aorta begins immediately after the left subclavian vein comes off the arch. So some people say everything beyond that is descending thoracic aorta. And the reason that that's often preferred as a definition is because in pathology like aortic dissection, the position of the dissection with respect to your left subclavian vein is considered to be critical. So anything that happens, any dissection that's distal to that is considered a type B dissection, which is less high risk and it tends to be managed medically, so with blood pressure control. Anything that is proximal to the left subclavian artery is considered a type A dissection and is high risk and is normally managed with surgery. And that's why we prefer to use that definition of what's arch and what's descending aorta rather than considering the T4 level. The other thing is, this is classic anatomy. In classical anatomy, the arch stops at T4, but there's huge variation in patients in real life, whereas the position of the left subclavian is far more consistent, hence more useful in clinical practice. So the thoracic aorta gives off a whole bunch of branches within the thorax. So it gives off the bronchial arteries, your mediastinal arteries, which are both paired, your esophageal arteries, and your pericardial arteries, which are in the midline, and then superior phrenic and posterior intercostal arteries, which are again various paired arteries. They're all very small. You probably don't need to know a huge amount about any of these arteries for your exams, so we're not going to go into that much more detail in this lecture. We may do in further lectures we do specifically talking about the aorta though. The other structure, the other vascular structure within the posterior mediastinum that's worth knowing about is your azygos vein. So it's a unilateral vein, and you find it on the right side of your vertebral column. And it originates actually in the abdomen, behind your IVC, and it's the union of your right ascending lumbar vein and right subcostal veins. And it ascends next to the vertebral bodies, just to the right. And it carries deoxygenated blood from your posterior chest wall on the right and your abdominal walls, predominantly on your right, sorry. And as I said in the lung lecture, it curves round your right main bronchus at roughly the T4 level, and then it attaches into the posterior part of your SVC and returns blood that way. You've also got your hemiazygos and accessory hemiazygos veins. So your accessory hemiazygos vein drains from the superior part of your left hemithorax to your 4th to 8th posterior intercostal veins, and it joins the azygos at about the T8 level. Your hemiazygos vein is basically a mirror. It was very similar to a mirror image of your azygos vein. So it comes from the abdomen and it drains the more inferior intercostal veins posteriorly, as well as your left subcostal and some of your esophagus. And it joins the azygos vein at about the T9 level. And this diagram shows it quite well. So this is your azygos here. This is your hemiazygos, which joins here, and then your accessory hemiazygos, which is here and joins a bit higher. Esophagus is obviously an important structure within the posterior mediastinum. It's a muscular tube, and its job is basically to get food from your mouth to your stomach. Part of it is also within the superior mediastinum, but most of it is in the posterior. It's originally slightly to the right, but as it goes down the chest or down the thorax, it goes towards the left-hand side, and it's surrounded by the esophageal plexus, and it passes through the esophageal hiatus of the diaphragm at the T10 level. So this is question 8, which is our last question. So we've got 51% of people who have said the right side of the head and neck is the only locations that are not drained by the thoracic duct. And then we've got 26% who've said abdominal wall, and then a smattering have gone with the other options. So 51% of you are correct. So the thoracic duct is the largest lymphatic vessel in the body. It ultimately drains into your left subclavian vein, but it receives lymph fluid from most of your body. So it starts up in the abdomen, and it enters the thorax and passes up the thorax and then arches around and enters your left subclavian vein. So it covers almost the entirety of your body, with the exception of the right side of your head, neck, and arm and upper thorax, which is all supplied by a smaller vessel, which is your right lymphatic duct, which goes into your right subclavian vein. The thoracic duct isn't something you can see on imaging normally, but it's still important for various reasons. So it originates at your cisterna chyli, which is at the lower end, which is within the abdomen, sorry, high up within the abdomen. It's immediately right of your aorta, and it passes into the chest through the aortic hiatus. As it goes up the chest, it tends to be slightly to the right, or directly anterior to the vertebral bodies. And about the T6 level, it then passes to the left before it goes into the left subclavian vein eventually. Why is this important? Well, a couple of reasons. So first of all, because your thoracic duct supplies most of your abdomen, and you've got lymph nodes that surround the duct all the way, and particularly at its termination with the vein, if you get a lymph node here, a pathological lymph node, typically this will be lymphatic spread from an abdominal malignancy, and classically it will be from a gastric malignancy. So you can get gastric malignancy, lymphatic spread, and then a pathological lymph node here, and that's called a Virchow's node. So it's not it's quite rare, but it's something they love to ask you about in questions. And obviously this would make it essentially metastatic because it's come from the abdomen, is now in the chest, or even technically the neck. So that's a good thing to know. The second thing is, sometimes if you do surgery in the chest, you can disrupt the thoracic duct. And if you disrupt the thoracic duct, you can get a chyle leak, and a chyle leak can often present as a pleural effusion. And the side in which you get the pleural effusion depends on where exactly you've damaged the duct. So if you damage it below T6, you tend to get a right-sided effusion. If you damage it above T6, you tend to get a left-sided effusion. So if you have a patient who's had some kind of thoracic surgery, now presents with an effusion, you put a needle into the effusion, take some fluid off, look at it, do some biochemistry on it, work out that it's actually chyle. You can infer based on where the which side your effusion is, you can infer roughly what level you've damaged the thoracic duct. And then that can then help you decide how to approach trying to surgically fix it or what to do next. So that's all our questions. We have 2 questions on the question and answer. The first one is, are the bronchial and mediastinal arteries paired? And then the superior phrenic and posterior intercostals were a separate pair. So they are, so the bronchial arteries are not, the bronchial arteries come off anteriorly, so they don't come off laterally from the aorta. So normally when you say something is a paired artery, they're arteries that come off laterally, and there are 2 of them, 1 for each side. The bronchial arteries come off anteriorly, so are not technically paired, and also sometimes there's more than 1 on each side. The mediastinal arteries, actually, I'll have to go up and check. I believe they come off anteriorly as well. I'm not sure how many there are, but I'll check that in the break and I'll tell you the answer to that. The superior phrenic and the posterior intercostal arteries, so they're not, each of them is a pair. So you've got a left superior phrenic and a right superior phrenic, and that is a pair. And then you've got multiple posterior intercostal arteries for various intercostal spaces, and each level, so say for example the 10th one, left and right is a pair, 11th left and right is a pair. Hopefully that makes sense. Somebody has asked, can we go through the difference between question 5 and question 6? Yes, we can. So this is a little bit tricky. So question 5, we're asking what's the posterior border of the middle mediastinum. And then in question 6, we're asking what's the anterior border of the posterior mediastinum. So basically that's the same border. Anterior to this border is the middle mediastinum, posterior to this border is the posterior mediastinum. So the pericardium is technically within the middle mediastinum, but that is the border. So hopefully that makes sense. Are there any other questions? So if we've got no other questions, what we'll do is we'll take a break for 7 minutes. We'll come back at 11, and then we'll go through the last lecture, which is diaphragm. As before, if anybody has any additional questions, please feel free to put them in the Q&A and I'll answer them at the start of the next lecture. And in the meantime, I will just check my anatomy textbook about the mediastinal arteries, and I'll give you an answer to that at the start of the next lecture as well.